Assalamu alaikum, I am Dr. Junaid and I am Senior Registrar in Pediatrics at Rawalpindi Medical University. Today I am going to tell you about the different Viva questions that can be asked in the examination of respiratory system. The examiner may ask you, what will you look at inspection? So you need to say that I will look for respiratory rate, type of respiration, shape of the chest, any deformities, any prominent veins, any scars and the chest movements. He may ask you, what is the normal respiratory rate? The normal respiratory rate is, the cutoff limit is 60 if the age is less than 2 months. The cutoff limit is 50 per minute if the age is 2 months to 1 year. And the cutoff limit is 40 per minute if the age is 1 year to 5 years. He may ask you, what are the type of respiration? The respiration is thoraco-abdominal if it is a female, and it is abdominothoracic if it is male. He may ask you, what is acidotic breathing? The acidotic breathing is fast and deep, and it occurs in conditions like renal failure and ketoacidosis. He may ask you, what is kind stroke breathing? Kind stroke breathing has a special character. There are periods of overventilation alternating with periods of apnea. The kind stroke breathing may occur in left ventricular failure, may occur in increased intracranial pressure, may occur in space occupying lesion of the brainstem, and it may occur in narcotic overdose. The examiner may ask you, what is the normal shape of the chest? The normal shape of the chest is elliptical, and the AP diameter and the transverse diameter have a ratio of 5:7 normally. He may ask you, what is Battleship chest? So when the anteroposterior diameter and the transverse diameter they becomes equal, the chest is barrel shape. It occurs in emphysema. Also remember that the anteroposterior diameter is increased in kyphosis also. Then he may ask you, what are the different deformities of the chest? Pectus carinatum, pectus excavatum, Henson Sulcus, kyphosis, scoliosis are the different deformities of the chest. He may ask you, what is the difference between pectus carinatum and pectus excavatum? And remember that the pectus excavatum has a word cave. So cave andar ki taraf dhasa hota hai. So when the chest is curved inwards, the sternum is depressed, it is pectus excavatum. When the sternum goes out, it is pectus carinatum. Pectus carinatum is also called pigeon chest, and pectus excavatum is also called funnel chest. Remember that the pectus carinatum can be due to chronic respiratory disease, whereas pectus excavatum or the funnel shaped chest is a developmental anomaly. The pectus carinatum can also be seen in rickets also. Then about Henson Sulcus, it is a groove at the lower part of the chest, just where the diaphragm muscles they get attached. It is also a sign of chronic respiratory disease. The examiner may ask you, what is the difference between kyphosis and scoliosis? Remember that in kyphosis there is increased backward curvature of the spine, and in scoliosis there is increased lateral curvature of the spine. The examiner may ask you, what are the causes of local bulge? Like if the patient is having bulge on one side, what are the causes? The bulge can be caused by pleural effusion, by pneumothorax, or by underlying fracture or malunion of the ribs. He may ask you, what are the causes of retraction of one side of the chest, of local flattening of one side of the chest. So underlying fibrosis, underlying collapse, cavitation, or pneumonectomy of one side or the other may lead to local retraction of the chest wall. The examiner may ask you, what are the causes of decreased movements of the chest. So again, pleural effusion, pneumothorax, consolidation, collapse, fibrosis, they can all lead to decreased movements of the chest. The examiner may ask you, why did you palpate the trachea? So you need to answer that I was checking for the push and pull of the trachea. Then he will ask you, what are the causes of push and pull of the trachea? The trachea is pulled by consolidation or collapse, and it is pushed by pleural effusion or pneumothorax. The air or the fluid can push it. The examiner may ask you, what are the causes of reduced chest expansion? Emphysema, bronchial asthma, fibrosis or ankylosing spondylitis can lead to decreased chest expansion. How will you measure the decreased chest expansion? With the help of measuring tape. If the chest expansion is 5 cm, it is okay. If it is less than 2 cm, it is considered to be decreased. Then the examiner may ask you, what are the causes of increased vocal fragmentus and decreased vocal fragmentus? Remember that increased vocal fragmentus have the same causes as that of increased vocal resonance, and the vice versa also. Whenever there is consolidation collapse or collapse with patent main bronchus, the sounds will be increased. Whenever there is fluid, more air like pleural effusion, pneumothorax, or there is collapse with obstructed main bronchus. Obstructed का मतलब ये है कि air आ तो रही है, जा नहीं रही. So you will have more air. In all these cases, the vocal fragmentus and the vocal resonance will be decreased. Then the examiner may ask you about some questions about percussion, where we do it normally. Anteriorly, above the clavicle, then on the clavicle, then below the clavicle. And then from the second intercostal space to the sixth intercostal space. And laterally from the fourth intercostal space to the seventh intercostal space. We don't percuss on liver and we don't percuss on heart. Posteriorly we percuss on the apices and then on both sides of the midline, about 4 to 5 cm below the spine of scapula, till the 11th rib. The examiner may ask you about what is the normal percussion note. So the normal note is resonant. We normally have air in the lungs, it is resonant. When we will have more air like pneumothorax, it will be hyper resonant. When we will have consolidation collapse, it will be dull. When we have fluid like pleural effusion, it will be more dull, stony dull. If you percuss on wood, it sounds like dull. If you percuss on floor or tile, it sounds like stony dull. Then the examiner may ask you, what are the causes of decreased breath sounds when you do it on auscultation? So the breath sounds can be due to decrease, again due to fluid, more air like pleural effusion, pneumothorax, or if there is thick pleura, or if there is collapse with obstructed main bronchus, and again in which there is more air inside, or if there is emphysema. Whenever there is, so I repeat, whenever there is more air, more fluid, the sounds will be decreased. The examiner may ask you, what is normal vesicular breathing? What is the difference between normal vesicular breathing and bronchial breathing? Remember that normal vesicular breathing has no pause. The inspiration is prolonged as compared to expiration. And the quality of sound is rustling. In bronchial breathing, there is a pause between inspiration and expiration. The expiration is as long as the inspiration, and the quality of sound is blowing as you blow in a windpipe. If you want to hear bronchial breathing, put a stethoscope on the windpipe, on your windpipe trachea, and just listen to the breath sounds. They will be blowing in character. He may ask you, what are the causes of bronchial breathing? So if you have consolidation or collapse in the lung, or if there is collapse with patent main bronchus in which the air is coming in and out, you can have bronchial breathing. Then he may ask you, what is the difference between rhonchi and creps? The rhonchi have a whistling and musical quality. Creps are just like जैसे पत्ते चरचरा रहे होते हैं. The rhonchi are seen in bronchial asthma, emphysema, and chronic bronchitis. Whereas the CREPS can be heard in pneumonia, tuberculosis, bronchitis, bronchiectasis, and lung abscess or pulmonary edema. Remember that CREPS are always inspiratory. They can be pan-inspiratory or they can be end-inspiratory, but they are always inspiratory. He may ask you, what are the causes of pan-inspiratory CREPS and what are the causes of end-inspiratory CREPS? So remember that there are only two causes of end-inspiratory CREPS, or there are only two conditions in which you have end-inspiratory CREPS. Otherwise, all the conditions will have pan-inspiratory CREPS. The two conditions which have end-inspiratory CREPS include pulmonary edema and fibrosing alveolitis. The rest of the conditions which we commonly see in our ward, like tuberculosis, like lung abscess, like pneumonia, they have pan-inspiratory CREPS. Then the examiner may ask you, what is pleural rub? Pleural rub is the sound which is produced by the rubbing of the inflamed pleura. He may ask you what is the difference between pleural rub and crepitations. So rub is heard at the end of inspiration. CREPS are always during inspiration. So the intensity of the pleural rub will be increased if you press the stethoscope, because the stethoscope it gets more close to the pleura, the sounds will increase, whereas there is no effect on pressing the stethoscope on CREPS. CREPS can be changed on coughing, whereas pleural rub will not be changed on coughing. Then the examiner may ask you what are the difference between exudative pleural effusion and transudative pleural effusion. So remember that if the proteins are more than 3 grams per deciliter, it is exudative pleural effusion, and if the proteins are less than 3 grams per deciliter, it is transudative pleural effusion. Tuberculosis and malignancy and pneumonia have exudative pleural effusion, and failures like heart failure and liver failure and conditions of hypoproteinemia like hypoproteinemic state like nephrotic have causes of transudative pleural effusion. Usually in different conditions the color of fluid is straw color like in TB, but in malignancy it is usually hemorrhagic. In pneumonia it is also straw color. The cells in tuberculosis are always lymphocytes, whereas the dominant cells in pneumonia are polymorphs. Then the examiner may ask you, what is the difference between type 1 respiratory failure and type 2 respiratory failure? Remember that in type 1 respiratory failure, there is hypoxia. There is only hypoxia, whereas in type 2 respiratory failure, there is hypoxia as well as hypercapnia. Type 1 respiratory failure is more common, as we see commonly in bronchial asthma and pneumonia. Type 2 respiratory failure is seen in conditions in which, in conditions like chronic bronchitis, emphysema, or the conditions in which there is respiratory muscle paralysis. So I hope this video will help you in your examination, and this was all about different Viva questions that can be asked in the examination of the respiratory system. All the best. Thank you so much.